Hi, I'm Dr. Bob Yetto of the University of Buffalo School of Dental Medicine, Department of Restorative Dentistry. I'd like to talk today about tooth whitening. I like to call this lecture OxyClean for the Mouth because of the impact whitening seems to have on everything in our society. We want whiter laundry, whiter bathrooms, whiter teeth. What's the difference? Well, if you're the late Billy Mays, you could sell OxyClean for anything. Along with veneering, whitening is one of the most often requested cosmetic services that we offer. But you need to be aware not all people are good candidates, and that's why it's important to screen candidates before you actually undertake this type of work. Let's take a look then what the indications and contraindications for whitening are. First, nature. Some people are simply born with a darker shaded tooth based on the genetics they inherit. As we age, the tooth will darken, presumably because there's more staining in the enamel surface. There are also pulpal changes that can lead to a darkening tooth with age. Endodontic therapy can result in a darkening of the tooth as a consequence of treatment, but there is an iatrogenic component. We don't want to leave any of the filling materials that we use to seal canals in the coronal aspect, especially of an anterior tooth, because that can cause chemical reactions that will later darken the tooth. Tetracycline therapy is not as great a problem as it used to be because it's a well-known cause of discolorations in the teeth. In orthodontic therapy, though traditional bracket therapy can still result in decalcifications on the tooth surface, which really are not a good responder to the whitening process. There's other ways to account for those types of maverick spots, but we get a little bit less of that nowadays because more clear aligner therapy is being done. Lastly, all of this is media driven. Of course, as Billy Mays can sell OxyClean for anything, so too we want to do anything we can to keep our youth, especially the aging baby boomers. Now looking at the contraindications for treatment, certainly unrestored caries, unresolved periodontitis, tooth sensitivity, those are all obvious things to a dental audience. Extensive anterior restoration, however, is something patients may not understand can lead to more invasiveness and more cost of treatment. These things certainly need to be considered by both the patient and the clinician, as each will contribute to the practicality, invasiveness, cost, and success of whitening. Contraindication number 5 will be covered in a few slides, in which some teeth could see little result or actual lowering of value. Can you think of when and why this could be? There's basically 3 types of tooth discoloration. First, extrinsic stains that are on the surface of the enamel, often eliminated during a prophylaxis. Intrinsic stains that are essentially stains from the surface that have now percolated into the enamel, and this is most often the primary indication to undergo a whitening process. Thirdly, maverick stains, such as white spots from decalcification due to orthodontic brackets. And as I had mentioned earlier, they're not always the best in terms of response to the whitening process. We'll talk about that in a few slides. In this case of orthodontic scarring, there are both dark brown and white opacities in the enamel. What will whitening do in these areas of the teeth, and how will they match or blend into the cervical, middle, and incisal areas adjacent to them? Intrinsic stains can also be managed by the veneering process. A patient who may have more considerations than color to improve in their smile may request this approach. It can be done with or without whitening as a precursor in order to create a more translucent overlaying veneer. Maverick stains usually do not respond to whitening alone and will require physical removal prior to a direct or indirectly placed restoration. They do respond to the application of remineralization products such as MI paste. Certainly we know now that tooth whitening is safe and effective, but in reality, whitening is a misnomer. We should refer to the process as tooth brightening or lightening. We don't take a yellow tooth and make it white, as if it's changing its hue. We decrease the saturation of color, which raises value and thus appears brighter or lighter than pre-treatment. But please, not bleaching. Leave that for the laundry room. Here now those problematic teeth that I referred to earlier that could actually decrease in their value. So a tooth with a strong chroma in the dentin and a translucent enamel with resultant low value can appear even darker after the removal of surface stain in the enamel, which would increase its translucency. You must take care to not do a walking bleach for more than approximately 2 to 3 weeks of treatment. This is a radiograph of an endodontically treated tooth that underwent internal bleaching for too long a period of time, resulting in an internal resorption. There are 4 main chemicals used in tooth whitening: hydrogen peroxide, carbamide peroxide, which degrades into hydrogen peroxide, sodium perborate or percarbonate, and hydramide peroxide. Low concentration hydrogen peroxide is the active ingredient in most strip delivery systems. Most dentist dispensed products for home use are carbamide peroxide, which is more stable for shelf life. When mixed, these result in about 1/3 the concentration of active hydrogen peroxide. That is, a 22% carbamide peroxide breaks down to approximately 7.5% hydrogen peroxide. The core product, developed by Dr. Rod Kurthy, is a proprietary formula which is manufactured and shipped in a cooled environment to ensure freshness for the end user. Read this slide carefully. Carbamide peroxide breaks down into hydrogen peroxide, but don't ever tell a patient about the urea part. When the hydrogen peroxide in the whitener breaks down, oxygen escapes as free radicals, which break the double bonds in long chain molecules of stains, creating shorter chain molecules which are seen as a lighter color. So keeping high concentrations of hydrogen peroxide at the time of application to the tooth surface is the key to efficacy, hence the effort to provide stable materials for our use. Once again, these over-the-counter type products are typically a low concentration of hydrogen peroxide. Of course, Madison Avenue loves the many permutations of essentially the same product, strips of polymer with hydrogen peroxide on them. Crest makes White Strips Classic, 3D, Pro Effects, 3D 2-Hour Express, Renewal. There's a lot of different products. They're all the same thing. Pens and other brush-on gel applications can be useful for single discolored teeth or in cases with persistent dark teeth needing more repeated exposures to continue the process after initial treatment. Blockout for reservoir creation is no longer a standard for most products. Does anyone know why that's now the case? You must scale up at least the facial of the tray to ensure patient comfort and thus compliance with take-home trays. The main difference between day white and night white is chemistry. Day white is hydrogen peroxide, while night white is carbamide peroxide. The Discus dental product line, now owned by Philips Oral Healthcare, is the one I choose because it has consumer-friendly packaging and information. This anterior maxillary veneer case chose whitening to improve the appearance of the mandibular anterior teeth. At-home tray treatment resulted in a lightening effect from an A4 to an A2 in value. The patient no longer requested anterior veneering of the mandibular teeth. Once again, this is not laser whitening, as many people erroneously believe. In fact, the role of the lamp or light in any of these systems is to warm the peroxide gel to accelerate the chemical reaction that releases the free radicals that break the long chain bonds. Here is the original zoom, through zoom 2 and then to zoom advanced power with a change in the lighting technology. C4 baseline is taken, Note the extensive anterior restorations, however. Care must be taken to apply the barrier in a complete fashion. Can you see the exposed gingiva in the maxillary left quadrant? After application of gingival barrier and whitening agent on the teeth, the patient is reclined with the light position directly over the oral cavity. Note, eyewear for the patient is essential. Once the process is completed, you will see the gel has become a foam from the release of oxygen. This C4 case finished at C1 in the mandibular teeth and about a C2 in the maxilla. Note how the remaining anterior restorations now are much darker in color as compared to the lightened teeth.